Okay. All right. Thank you very much, folks, for joining us for our inaugural Honors Colloquium of the Fall 2024 season. And I suppose the first Honors Colloquium of the Honors College here at A&M Texarkana. So I do want to apologize, as I said before. I dropped the ball on the refreshments. So in future colloquiums, as my colleagues are making sad faces in the back of the room, I do normally try to provide some basic refreshments. And just thought about it and forgot. So my apologies to you all, and of course to our speaker, who does not get the benefits of watching a cup of coffee get cold while she speaks. So our speaker today is one of our honors students, biology major, Sinead Smith, and she is going to be speaking to us today about the opioid crisis epidemic in Texarkana. This is part of a project that Sinead worked on with Dr. David Yells, who is the division chair of social and behavioral science here at A&M. After her talk, hopefully we'll have a little bit of time for questions. And I will now get out of the way and man the Zoom. If you could sign in at the back when you come in, that'd be delightful. All right, Sinead, take it away.
Okay, so we already know that opioid is a huge problem in America, but we kind of forget about how much a problem it is in our individual cities and how it impacts us as community and what we can actually do to address the problem. So what are opioids?
You want me to advance? Oh, okay, I try. There we go. Got it.
Okay. So basically, we look first at opioid use disorder, which is the problematic pattern of opioid. Okay, this is an old one, but we'll keep going. The problematic pattern of opioid use leading to clinically significant impairment or distress. So basically, you've got a whole lot of symptoms that you have to meet in order to qualify that as that. And we say that opioids have a huge addictive tendency. And part of the reason why opioids are so addictive is because of this concept of tolerance and withdrawal. Tolerance just means that every time you use opioids, you need a little bit more and more and more to have the same effects. Withdrawal means that as soon as you stop using opioids, you tend to have very negative consequences and negative symptoms as well. So that's how we characterize opioid use disorder. And there's a range of physiological impairments that you get. You can get, if it's an IV user, you get sclerosed vein. If it's an insufflation, so basically when someone inhales the opioids, you can get a deviated septum or deviated or perforated septum as a result, and it's nasty. The latest symptom that has started coming up is actually flesh-eating bacteria upon injection, and I have pictures, but it's really gruesome, so I decided not. In any case, the most serious consequence of opioid use disorder is opioid overdose and a fatal overdose, and that's essentially what this project is looking at is how do we prevent a fatal overdose from occurring? Now, we already know that it's a problem in America, but now let's talk a little bit more of the numbers game. So Arkansas has the second highest opioid prescribing state in the United States, which means that there's a lot of people that are being prescribed opioids and using opioids on a consistent basis. And one of the reasons why this is so, is it still the wrong PowerPoint? Still the wrong PowerPoint. Oh, sorry. It's okay. That was my fault. So it's a really bad problem in that we prescribe a lot of opioids that are not going to actually do their effect, but rather create more and more of a burden on the health population. So if we look at the numbers, more than 1 million people in the United States have passed away as a result of an opioid overdose since 1999. So in March 2022, the 12-month period preceding that, there were 109,000 people that died as a result of an opioid overdose. The annual overdose deaths reached record levels during the pandemic, and I've got some data that we can sort of correlate with that as well. And over 150 people die every day from an opioid overdose related to synthetic opioids. Now, your synthetic opioid, you're looking at fentanyl. So fentanyl is a very good example of a synthetic opioid, and it's the leading cause of death in the US adults ranged 18 to 45. So at this university, we're looking at a very problematic group, because if you look at the leading causes of deaths across the world, typically in the United States, you're looking more at your non-communicable diseases. You're looking at heart failure, diabetes, cerebrovascular accidents, which are your strokes. But now we've seen a switch. So no longer are those non-communicable diseases are no longer the leading cause of death in the United States. At the moment, it's currently actually opioid overdoses, which is terrifying. Okay. Then in 2023, the DEA released some statistics on the fentanyl that they had seized. So 7 out of 10 of the pills seized by the DEA were actually containing a lethal dose of fentanyl. They seized more than 379 million doses of fentanyl in 2022. And in 2023, just Texas alone seized enough fentanyl to kill 200 million people. And that's just what the DEA is seizing. And currently they're saying that the amount of drugs that the DEA seizes is only 10% of the available fentanyl or drugs on the market. So the math gets a little bit scary when you think of all the drugs on the market, or all the fentanyl on the market. The DEA is only seizing 10% of it, and the 10% it seizes is enough to kill 200 million people. Okay, so
I'm gonna see what the next one is.
it's the wrong PowerPoint, so we can go with this one.
All right. Which one?
We can go
Back or forward?
that one.
Okay.
We'll
Run with this one.
We'll run with this one.
That's
okay. So every year we need to think again, okay, what is the cost of opioid overdose? We've obviously got lives lost, which is a huge cost of an opioid overdose. But we also have $35 million in healthcare costs that we lose every year. So if we look at the annual healthcare costs, people who have had an opioid overdose accounted for $1.94 billion of those annual healthcare costs. Then you've got $14.8 billion in the criminal justice setting as those costs. And each dollar invested in addiction treatment reduces drug-related crime, theft, and criminal justice costs by $4 to $7. So we really want to emphasize the idea of putting in more costs towards treating addictions, because that's going to ultimately save lives and save money. And we also had a $92 billion loss in productivity due to premature deaths resulting from overdose, productive hours lost to opioid use disorder, and opioid-related incarceration. So we're not only losing time, we're losing money, and we are losing a lot of people. So a lethal dose of fentanyl. Does anyone want to guess how much a lethal dose of fentanyl is?
Isn't it like a grain of salt?
Almost just so that's carfentanil.
Okay.
But 2 milligrams of fentanyl is a lethal dose. 0.02 milligrams of carfentanil is a lethal dose. So these numbers are really, really, really small. I mean, if you've ever sat with a scale or a mass balance trying to measure out 2 milligrams takes a long time, and it's very, very easy to make a huge error. So 2 milligrams of fentanyl can kill you. 0.02 milligrams of carfentanil will kill you as well. So think of it as the amount that can fit on the tip of a pencil. That is a lethal dose of fentanyl.
Great.
Okay.
Can I just ask, what's the difference between those two things?
The difference between the two things is they are isomers of each other. So they're both synthetic opioids, but they've been reformulated in different ways, because one of the benefits of synthetic opioids is that you typically have you reach your high quicker and it's for a shorter duration and it's got a higher addictive potential. So basically it's more potent. So opioids like fentanyl is even 50 times more potent than heroin and 100 times more potent than morphine. Cool. So it reaches that high faster, easier, but the high lasts for a shorter duration of time, which ultimately goes in towards the model of the drug syndicates, because if you get more addicted to it more quickly and your highs for a shorter amount of time, you're going to buy more.
Right. Thank you.
So that's scary.
Yeah.
But so these are your opioid receptors. And so basically how this works is in your brain, you have opioid receptors. They're called opioid receptors. And what happens is when you use an opioid, they bind to those receptors in your brain, and that's going to induce quite a few different reactions. It can induce analgesia, which is what opioids were primarily marketed for, was their pain-reducing effects. And so depending on which opioid receptor it binds to, it's going to reduce different levels of analgesia. You're also going to have a feeling of euphoria, which is the high, which is the good feeling. And basically, what it also does is, and this is how it causes an overdose and a fatal overdose, is it causes respiratory depression. And what that basically means is it blocks the signal to your brain, which allows you to breathe, which means you're going to stop breathing. And what happens when we stop breathing? Nothing very good. So if we look at public health, what we can see is that we've got what is public health. So we're looking at science of protecting and improving the health on a population level. So we're looking at promoting healthy lifestyles, researching diseases and injuries in order to figure out how we can best prevent them and respond to infectious disease. So it's a collective effort to promote health and prevent communicable and non-communicable diseases involving population surveillance. Who's getting what, where, and why? Regulation of the determinants of health. So you've got many determinants of health, and a lot of them can be it's a biopsychosocial model of health. What's going on biologically? What's going on psychologically? What's going on in your social sphere? All of those affect your health. And then the provision of health services with an emphasis on prevention. So what we see with public health is that we attempt to intercede at the lowest level possible. So try to prevent it right at the beginning rather than just treating the cause. And so these are our levels. We have primary, secondary, and tertiary. Primary is what we can do beforehand to stop it from happening. Secondary is early screening. What can we do to stop it getting worse? Tertiary, the worst has happened. How do we handle it? Now, from a public health level, we really want to be operating at a primary or primordial intervention level, which is quite high upstream, in order to prevent the downstream consequences, because the downstream consequences are often of a higher cost, whether it be an economic cost, a social cost, or a health cost. So this is how I was taught the public health. We've got a hole in the bridge. Okay, primary health care is going to be patching the hole in the bridge. Secondary health care is going to be tossing a buoy to the people that have fallen in the river. Tertiary healthcare is going to put a net at the end of the waterfall and hope you save some lives. So we really would prefer to be on a primary prevention level. Now, there's a lot of things that can impact what happens to a person who develops opioid use disorder, opioid addiction, and results ultimately in an opioid overdose. So at a primary level, what we really want to do is we want to negate having negative childhood experiences. We want to provide accessible and affordable care. We want to mitigate stress. We want to have sufficient provider capacity and reimbursement, meaning that if you go to a doctor and there's the hint of a problem, the doctor can step right in there at that point and prevent that problem from developing. Then, doctor or health professional. social support, connectedness and opportunity for socialization, investments in evidence-based promotion of parental and intergenerational health, community vitality and economic opportunity, support for resource-limited families and individuals. Now, this looks very far removed from the healthcare setting. That's because it is. And that's really what we need legislation to draft around, is these very initial protective factors, so we prevent the development of the need to firstly use opioids and secondly develop opioid use disorder and then go into an opioid overdose. So that's where we begin. And then on the next level, we see, again, we have methadone or medication-assisted treatment for opioid use disorder. That's using methadone and buprenorphine. You're already addicted to opioids. What can we do to get you off illicit opioids and control the condition so that you don't overdose? Stable housing, economic stability. We need substance use services, peer recovery support, housing and workplace management. All of these are going to contribute to preventing opioid overdose. Now, if we go onto a tertiary level, overdose has happened. This is the worst case scenario. What can we do about it? Now, this is where we look at, okay, where the research that I was doing really comes in, and we look at bystander and naloxone provision and other approaches to widen the availability of naloxone. Naloxone is just this generic name for Narcan. So how can we get it out there to more people? Because it is one of the only things that can actually reverse an opioid overdose and prevent a death. So, and this is where I got all the statistics from. Okay, so if we look at overdose death prevention strategies, one back. One back. Ooh.
I don't think we have that one.
Okay, skip to science. Right, okay. So if we look at overdose death prevention strategies, we're looking at targeted naloxone distribution, medication-assisted treatment. We're looking at academic detailing, which is educating healthcare professionals. We're looking to eliminating prior authorization for enrollment in MOUD, so your medication-assisted treatment for opioid use disorder. You're screening for fentanyl in routine clinical settings. You've got 911 Good Samaritan laws, naloxone distribution and treatment centers and criminal justice settings, and medication-assisted treatment in criminal justice settings and upon release from incarceration. But now this is how naloxone works. So we say that naloxone is an antagonist of the opioids because what it does is, instead of the opioid binding to the receptor, the naloxone binds to the receptor, preventing the opioid binding from it, taking the opioid off, and the person can remain breathing. That is how naloxone essentially works. It works really, really well. And it's not going to harm anybody. There's no negative side effects, which is really, really brilliant because most medication has negative side effects. Then we look at opioid overdose. So here's a little bit of our numbers. If we look at the opioid-related deaths in Arkansas, it's pretty high, but it's lower than in Texas. And then we need to think, okay, why is it lower in Arkansas than it is in Texas? I will admit that during the pandemic, Texas decided to suppress its data, which means it's very hard to find data, but we manage. So we've already got a high and a continually increasing trend of opioid overdose related death. And we have an increasing trend of opioid overdose use or opioid use. And the research shows that even if it wasn't opioid, another drug would be used in place of opioids. But we don't like opioids because it's so easy to kill you. Okay, the next one. All right. Okay. Then if we look at naloxone, so here's possibly one of the reasons why Arkansas has less opioid overdose deaths than Texas, even though it's got a higher prescription rate per person. Naloxone distribution. So here we have Texas, And it's one of the lowest naloxone distributions in the United States, sitting at around about 0.2 per 100 people. Whereas in Arkansas, they've really climbed up to 13.9. And so Arkansas have really been enrolling in there, trying to get into this point where they can actually intervene and prevent a fatality from an opioid overdose. So if we look at opioid overdoses, we see that 44.3% of opioid overdoses in Arkansas in 2022 had an opportunity for prevention for intervention with the bystander present. So there was someone there witnessing it that could have done something but failed to do something. We have 14.7% of people who overdosed that had a current mental health diagnosis, another opportunity for intervention. We have 6.7 fatal drug use witnessed. We have it was the 1.10 current treatment for substance use disorders, and we have 6.10% having had a prior overdose. So now, why did people not intervene when they were present? Remember, there was 44.3% of overdoses that had a bystander present that could potentially help. A lot of them said they were spatially separated from the decedent, so 45.40%, okay? Next one, 17.5% were unaware that the decedent was using substances. Then 34% did not recognize abnormalities. 16.5% did not recognize abnormalities as an overdose. And 19.6% were also at that point using drugs and alcohol. And the 1% was public space and strangers did not intervene. So then we need to think, okay, what can we actually do about it? This is Texarkana. This is the scary statistics. So, opioid dispensing rate. So how many people are picking opioids up from the pharmacy? In Texas, it's low. Bowie County. Arkansas, Miller County. So Texarkana has a real problem with opioids. And if we don't actually make ourselves aware of how to respond to an overdose or how to help people, unfortunately, we're going to be like that 44.3%, where 44.3% are going to die because we didn't know what to do. And that's not a nice thought to have. So if we look at who normally delivers Narcan, okay, Texarkana, Texas PD. So we can see here we had a huge increase of Narcan used during the pandemic, and you can see the overdoses are our blue line and the Narcan uses are our orange line. So obviously we are very short of Narcan availability on the Texas side, and we saw that with the previous Narcan distribution in Texas. Then if we look at LifeNet, we can see that our patients are increasing. This number, 82. There's been 82 overdoses on opioids from January to June of this year. That's already terrifying. What we can also see is that we're not having a single dose of Narcan and a single patient. For a lot of the patients, we have to use two doses of Narcan at the very least, because we're using stronger opioids or different synthesizers. And so, unfortunately, we're going to need to use more and more Narcan, but we don't have the supply. Okay. So if we look at LifeNet and Texarkana PD, we can see we had a huge one in 2021. There was a huge drug bust at that point when they found a lab in Texarkana and managed to hopefully root it out. But we can see that we are starting to have more patients and not enough Narcan available to do it or available to reverse these overdoses. So the challenges we have in combating these epidemic is that we have a suppression of data. There's no single clear route of communication for naloxone distribution, which is further complicated by the fact that we are a two-state city. And then the lack of active visibility. Because how many of us would have thought there's an actual large opioid program or problem here in Texarkana? We always feel like we are far removed from it, but it's actually a lot closer than we think. So there's a few programs that Texarkana has activated in an attempt to reduce these. The first one is the Medication Arkansas Take Back program. So you have 3 addresses within the circumference of Texarkana where any prescription pills that you have, if you no longer need it, dump it in there, because a large portion of the youth say that they get their medication from families, friends, or acquaintances, and then they have started what is a frankly, very, very terrifying concept of pill parties. So they take all the unused prescriptions, put it in a pill, pop a pill, overdose, life gets called. It sounds unbelievable, but it happens. You think it's really, really disturbing. And so in 2021, this Take Back program actually collected 28,020 pounds of medications. The next one is there's 2 apps for routes of communication. If someone overdoses, 911, they're going to call 911, and while you're waiting on 911, they're going to give you a guide of how to step through the procedure. There's Revive Arkansas and Texas Cope. Both of these very good apps. They're going to do the same thing. If you have just one of them on your phone, rather have it than want it. Then the last one is that we have OEMD, so that's opioid education and naloxone distribution workshops that we're currently running. The city of Texarkana, Texas side, I'm partnering with them to host a workshop on the 24th of September. And the first 200 people that arrive will receive a free box of Narcan. So we're really trying to drum that to get Narcan and naloxone distributed within the city, and hopefully in that way we can prevent overdose fatalities. Okay, and that's it from me. Any questions? So there are some insurances that will pay for it. It's really, Narcan is really easy to use. It's like nasal spray. So like a normal saline spray, you just all sorted. I think you can apply to get it for free if you go through UT Health, like San Antonio. They've got a suspension package. Otherwise, you're looking at approximately, it depends on where you go to. It changes the cost.
Is this like a really big process to get it?
If you go to a pharmacy, no, because they're really trying to get it spread through.
Do you think that more people should have it like available?
Yeah. Just for the pure part that like you had 44.3% of overdoses that could have easily been prevented. If you recognize the signs, you call 911 and you have Narcan on you. You can save so many people from that.
Dr. Cantrell, I think, had her hand up first. Sorry, Angie.
Thank you for such a wonderful and well-informed talk. I'm so excited about the energy coming out of the new Honors College, and this is a wonderful program to start us off with, especially because it's focused on our local community. I know in the city of New Orleans, they've also taken the workshop approach to get Narcan out into communities. They do a train-the-trainer model where they host a workshop. They train the community organization, the church group, whatever the social outlet might be, and then they distribute free Narcan. But the city also has specific pharmacy locations where anybody can walk in and get Narcan accessible for free. Now, the problem as you've identified is that a lot of the synthetic mixes, it takes more than one, right? But I mean, this is really, I mean, in the field of public health sector, and very rarely do we get opportunities where you can just spray something up someone's nose and it's all better, right? So the mere fact that this is just something that we need disseminated out into the communities is I think just as appalling as the epidemic itself, right? We have a solution. The fact that we just can't access it as readily as we would hope is equally as disturbing to me as the epidemic itself. So I'm wondering, I'm very long-winded way to ask, are you aware of CVS pharmacies or Walgreens pharmacies where people can go in and access market free? I know the city of New Orleans has an entire list of their site, and I was just thinking of this actually with a community group down there, a different community group, but I'm wondering if Texarkana has pharmacy, like a pharmacy list.
I think if Atlanta, Texas has it in their CVS, Texarkana probably will.
Okay.
Because it is in Atlanta, Texas CVS.
Yeah.
It's like, it's behind the counter and behind the.
You just have to ask. I think you literally just have to ask.
Because what's starting to happen is if you're prescribed an opioid, you get prescribed Narcan at the same time.
Yeah.
So they should have it in stock, very, very hopefully. And additionally, what we're doing, so on the 20th of August, we trained the carers. And on the 24th of September, we're training the community. So anyone from the community can come access that Narcan. And also Community Health Corps also has a supply of Narcan as well. They regularly get it free. And so they try to distribute it and hand it out to in the community as much as possible. And one of the options that we're also looking into, because the city got a huge settlement from that legal case, is creating an almost post box sort of thing of Narcan on state line. That's one possibility, but we're weighing the pros and cons on that at the moment.
It might be useful ensuring that MOTPD has it supplied.
They do. Good. They have got a supply of Narcan and they have training that they receive quarterly on administering it.
I'm so relieved to hear this. I love when things work.
So we have just a couple of minutes left, Angie and then Madison.
So, all right, so what you presented was, naloxone as being a competitive with an opioid, right? So it has higher affinity than the
Yes.
opioid of that.
Yes.
I picked it out. So how does Suboxone compare to naloxone?
I haven't actually heard of that at the moment.
Suboxone?
Suboxone.
It's similar to methadone.
Oh, okay. So
He says individuals who want to get off.
yes.
This time there's a prescribed, well, methadone, Suboxone is another one, a very popular one. There's a legal one. There's also a pill one. But I guess my question is, does that not have as high affinity as
So
the opioid itself?
you've got naloxone and you've got naltrexone.
Yes.
Naltrexone is used with medication-assisted opioid use disorder treatment, but it does not have, it's an antagonist, so it
Right.
prevents opioids from binding, but it does not have as strong reversal effects. Methadone and buprenorphine, which are medically assisted treatments, are actually opioid, but they're partial agonists, so they don't bind to the receptor with as high affinity, and it's hoping in doing that you can actually wean the person off the dose. The problem is MOUD, so medication-assisted treatment for opioid use disorder, is non-curative. So that means you can be on it, you can wean yourself all the way down, but you'll never be entirely cured of OUD. However, the naloxone is nice and easy formula just to reduce reverse an opioid overdose, but not necessarily to cure opioid use disorder.
Okay. Last question, Madison. Well, we can stick around.
Training.
It's 11:30 to 1. 11:30, from 11:30 to 12, you will be provided with a free lunch. And then from 12 to 1 will be the training at opioid education, so telling you everything you need to know, and Narcan distribution, as well as the training in the use of the Narcan, the steps followed.
Campus, like in the
It's at PT, the Truman Arnold Center.
Texarkana College. That was a short question. So do you have a question you want to end us on?
It's not a question, but I know End Overdose is like a website and Instagram that like ships you free Narcan and like training. So I think that's another website you can use.
End overdose.
End Overdose.
Cool. All right, well, I think we're pretty much running right up against when a class, I suspect, wants to come back and take this room. But let's go ahead and thank Sinead once again. Well done. Thank you. Great job. I will be in touch about our next colloquium, though I think it's a shared colloquium and place talk that may be me. So it won't be quite as interesting, I don't think, as what you just saw. But once I get the full colloquium schedule sorted, you will all get a copy. Thank you very much, folks.